your musculoskeletal specialist. What I thought we would do on this video is capture some of the treatment techniques you can use on our long and short adductor muscles. The adductor muscles are called adductor muscles because they add or adduct in. So that means anatomically, when we think about them, they're going to be attached around the pubic bone of the skeleton of Bruce and come in and attach it either of one of two places. One is along the femur on that medial aspect, depending on which muscle groups of brevis, or further down, depending on the muscles that we are looking at. Or we're going to be looking at some of the ones that are our longer adductors, and they attach to the 𝐴𝐵𝐵𝐿, and that's our sartorius, our gracilis, our semitendinosus. And we've got some that attach more at the distal part of the femur. What they do is assist on moving the leg in. So if Kristen's going to be moving her leg in that fashion, she's using the longer ones. If she's doing it like this, she's going to be using her shorter adductors. We're taking away the longer ones. And we can notice a couple of things. One, when she's lifting up her leg in this position, her leg is actually staying in a really lovely neutral position. The second that we bent her here and she came up, it's harder, and B, she's going into flexion, which is telling me a couple of things. It means that we need to address and help lengthen the short adductors. So that's kind of giving us an idea of where we're going to focus on. A lot of moves that we can do are quite painful, and we have to be mindful of what positions our clients and patients like. I don't like treating adductors with our clients lying on their backs if they feel any way uncomfortable or insecure in that position. Having them lying on their side with a pillow or a bolster to bring the upper leg out of the road can give me good access to all of these muscles without them feeling uncomfortable.
Correct.
Yeah. So if I walk my fingers up the adductors through this area, and I'll be explaining to her, I'm going to come up to the attachments, so where they attach up through here and up towards the pubic bone, and I'll explain that I'll come straight into where the crease of the buttocks is at the hamstring, and say I'm going to be coming around to about this area here. So they have a feeling that they know where we're going to stop in the treatment. Does that feel uncomfortable?
No.
No. Okay, so we just want to make sure that they feel really aware that there's not a privacy issue. And I'm just cross-fibering over that muscle group right now, and it does feel tight. Yeah? So I know that I'm going to have to be mindful in the treatment techniques I use. You'll be using an oil or a lubricant on skin, and we would have this area draped. But for you guys, we're just looking at fingers are going to come in at about 45-degree angle, so that we're sitting flush. We're coming up 45, sinking into the tissues, and then just slowly, gently gliding up through the tissue. Because we've got material, I'm just going to hold the material down, but in actual fact you could have hand over hand or fingers all attached, as in attached together, not fingers attached. And we're going to glide up until we find that taut band, and then we can cross fiber. And we can work all the way down. Once you find that taut ridge, you can actually follow it all the way down the medial thigh until its attachment point, and there's that secondary attachment point. So I'm going to go one thumb at the attachment point where it's tender, one thumb up at the top, or two fingers depending on your hands and positioning, and I'm going to push them together. Find one, find the other. So I'm sinking down into the tissue and I'm making them come closer together. So what we're doing now is a positional release technique. Positional release techniques are excellent to change the tension between the two ends of the muscle fiber. So we're going down, and together you can understand that that muscle is then much softer in the belly. And we hold it until we can feel a sensation at the tendons where it actually feels like it's softening. Now, because I've taken my fingers away from Kristen, I would have to reapply and sit here and listen quietly with good palpation fingers for about 90 seconds. So it's not a short time. It should feel slightly uncomfortable, but not dreadful.
Yeah, correct.
Yeah. Now I know that she's got short adductor problems as well as long adductor problems. So once we've looked at the long adductors, and that's starting to soften through the distal, yeah? We're going to come back up here, feel down, that's actually a lot softer too.
Less tender.
Yeah, so we're going to come in and probably address at a shorter range, so sinking down and proximal, sinking down and distal, have the muscles meet in the middle for another 90 seconds, or until you feel that the muscles start to give. Generally it's around about 90 seconds, so this is when you can ask more history questions. Sometimes they will remember things on the table that they forgot to answer that could be quite relevant. We see that all the time. And they go, oh, do you think it would have made a difference when I fell off the ladder when I was 6 and my coccyx broke? You know, yes. So this is a great time that you can get more history, and that's actually just starting to soften up here again as well. And then we're just going to feel, and that's actually, even though we're on material, that's gliding a lot easier for me. How's that feeling in there now?
Less tender.
Yeah, yeah. Let's do those reassessments. I'm going to get you to bring this leg off the table, and that looks easier. And down, let's flex, and coming up off the table. That actually looks better too.
Yeah.
Yeah, so a little bit still flexion, and I would address the rest of that in supine, but much more adduction and a lot better in the quality of movement. Great. I'm Paula Nutting, your musculoskeletal specialist.